This is a sponsored symposium by Novo Nordisk. I'm going to take extra few seconds here, and I thank Novo one more time because they allowed me to present my own slide deck here. For compliance purposes of the company, I would also include few slide decks provided by the company. So I am very grateful for that for Novo Nordisk. So I'm going to be talking on polypharmacy in type 2 diabetes. This is appropriate or cause of concern. This is a financial disclosure for this presentation today. So we'll move on to what is polypharmacy. Polypharmacy is use of more than 5 medications in our prescription. Most of this for a diabetic patient seem to be very, very appropriate, as the chairperson just mentioned it. But there is something also called as excessive polypharmacy or hyperpolypharmacy, where there is more than 10 medications in the med list. Then we call it as a hyperpolypharmacy. So if you look at the data of polypharmacy in the Western literature, it's somewhere around 50 to 60%. Around 30 to 40% of Caucasian population is more than 10 medications in the list of medications. But if you look at the published data from India here, 49% of our Indian adults over the age of 60 report polypharmacy of more than 5 medications, and about 1/3 of them have more than 10 medications in their med list, which is hyperpolypharmacy. If you look at the geographical distribution within India, whether northwest, South India reports a prevalence of about 49, somewhere around 42 to 57% as a prevalence of polypharmacy in Indian population. So if you look at the gender difference in polypharmacy, women population have reported more polypharmacy, more from self-medications of over-the-counter medication. But if you look at the diabetic complications or the outcome in women, again, were worse when compared to men. This probably could be the adherence related to the medication, even though the number of medications on the list could be much higher than the men. The compliance to medications could be lower. That explains why the diabetic complications, including heart disease or death from the cardiovascular disease, is higher in women when compared to men. So what are the risk factors for polypharmacy? One is a multiple chronic disease. We all as physicians, diabetologists, and endocrinologists, we don't only treat diabetes. We have to put them on ARB for hypertension. We have to use the appropriate medications for diabetes, as Joel mentioned about the guideline recommended or guideline managed therapies for diabetes, which increases the number of prescription in our patient population, or also statins, which is very mandatory. So we are dealing about multiple chronic condition, and this is true for any non-communicable disease. Advanced age, the longer the patient lives, the medication list also increases because they would be treated for osteoporosis or they would be treated for cognitive decline, etc. Multiple prescribers. I think this is one thing with the chairperson also mentioned. It's very important for us to medically reconcile the drugs. See, especially very true with vitamin D and other over-the-counter prescriptions. Patient would be taking multiple forms of the same medications without knowing what exactly they are taking. So that again is very important. Prescribing cascades. By prescribing cascades, we meet one common example. Yesterday, we had talk on prolactin, right? So a patient would be on a proton pump inhibitor with domperidone, and that would increase their prolactin level. They would present with irregular cycles, and then we'll put them on dopamine agonists to reduce the prolactin levels. So one drug that we use would lead to side effects, and we would use another drug to combat the side effect from the drug that we are already using. So that is prescribing cascade. Over-the-counter self-medications, very, very common, especially from the social media. We talked about the social media and the thyroid yesterday, right? So over-the-counter self-medications are very common. Inadequate review of the medication. Cognitive or educational barriers from the patients, again, could be one of the reasons for polypharmacy or hyperpolypharmacy. So the question that we are trying to answer here, this is not a debate. We are trying to answer whether this is appropriate for our population or is this a cause for concern, right? That's exactly what we are trying to answer here. For that, I have 2 clinical case scenarios. And then we will talk about whether this is appropriate or case of concern. So this is a 58-year-old type 2 patient who has been diabetic for the past 22 years, started as GDM, PCOS history, hypertension. He also has coronary artery disease, postmenopausal, also has osteoporosis, and also has insomnia history. So the medicine here, she's on 12 different medications that I have listed out. She's on degludec, liraglutide, ultra-fast-acting aspart at 10 units 5 minutes before breakfast. She's on SGLT2 class of drug that we talked about, statin, clopidogrel, metoprolol, antihypertensive therapy. Sometimes she uses melatonin SOS for sleep or as needed basis, a multivitamin that contains B12, calcium and vitamin D for her bones, and she's also on alendronate once a week for osteoporosis. So this medication list looks pretty complete, for the clinical history that we talk about in our patient. So just few words on basal and ultra-fast acting insulin before we move on. So the ideal basal insulin here should have a flat glucose lowering effect, should have a longer duration of action, a minimal variability, and low risk of hypoglycemia. Keeping that in concern here and cost of the insulin if it is not a concern, degludec here, which is called as Tresiba, which is an ultra long-acting basal insulin, would be an ideal setting because of the dosing flexibility that it offers when compared to the second-generation basal insulin that we use in our practice, or which we've been using for the past 25 years in our practice. And if we specifically talk about the ultra-fast-acting insulin, which this patient is on here, if you look at the normal pancreas, which is regular insulin versus ultra-fast-acting insulin aspart, it sort of approaches a more physiological insulin profile, and that allows us to dose this insulin just before the start of meal, as close to a start of meal of 2 minutes, or the dosing window can be about 20 minutes after a meal. So this can be convenient in daily life in a patient like the presented case scenario, or it could reduce the risk of hypoglycemia, and it could be used in inpatient setting, elderly population, patients with type 1 diabetes, gestational diabetes, in-hospital hyperglycemia. So there's a lot of clinical benefits of using ultra-fast acting insulin, again, if cost is not a concern for our patients, and especially in patients with irregular eating habits. So we'll move on to this clinical case summary number 1. So she's a 58-year-old lady, 22 years of diabetes, hypertension, CAD, osteoporosis, has more than 10 medication, would qualify for hyperpolypharmacy here, basal insulin, bolus insulin, she's on GLP, all guideline managed therapy. Whatever the guidelines recommend in terms of GLP, SGLT2, statins, antihypertensive, anti-resorptive therapy for the bones, she's on all guideline management therapy. So contrast this to the next clinical patient here. This is a patient number 2. So this is a 45-year-old woman who's been having diabetes for the past 5 years, dyslipidemia, metabolically associated fatty liver disease, poor lifestyle and sleep routine, attributed again to perimenopause. She still has regular menstrual cycle. Her BMI is 30. So she's on metformin, she's on sitagliptin, she's on a co-formulation insulin, given the concerns of the patient to go on a multiple insulin shots a day. She's on that for biggest meal of the day. She's on a statin. She's on saroglitazar, which is very commonly used in MAFLD. She self-prescribes vitamin E for MAFLD. Other than that, she takes curcumin, which is manjapodi, right? Self-prescription for diabetes, which is available over the counter. And she's also on zolpidem and clonazepam for sleep. Coenzyme Q, again, self-prescribes for muscle pain to prevent muscle pain from statins. Magnesium, again, very commonly used over-the-counter drug, and we see a lot of magnesium in use right now, which is about 2,000 milligram of magnesium glycinate is what she purchases from online pharmacy, and she takes it for sleep, aches and pains. And tablet glutathione, again, is very common for skin brightening, skin and hair health, self-medication of glutathione here. And progesterone she uses for withdrawal bleeding because she doesn't get her regular cycles. Here again, she's on 12 different classes of medications. We'll come about this case later. So we'll move on to 1 or 2 slides on insulin co-formulation, on why we are talking about this. So insulin co-formulation is a simple regimen because it has fewer injection and greater flexibility of dosing time. There is a fixed ratio combination of ultra-long-acting insulin and a short-acting insulin in the same pen, which is called as Rhizodec. So this is a soluble insulin analog combination which sort of combines and addresses both fasting and the postprandial blood glucose reduction. So this is how it is there in the pen, the Rhizodec pen, where you have 70% of degludec and 30% of insulin aspart here. Once inside the subcutaneous tissue, they separate. The IDEC forms dihexamers and the aspart forms hexamers. And aspart is rapidly absorbed into the bloodstream, and that's how it addresses the postprandial blood glucose reduction, whereas the degludec, by the degludec mechanism, which is also available as Tresiba, slowly diffuses, causing this sort of a basal insulin or the basal requirement. Combine both these things in the pen is what is called as Rhizodec, which is also called as the co-formulation insulin, as shown from the switch studies to improve efficacy, lower the dose requirements, reduce injection burden, and also improve the safety of our patients. So if you summarize this clinical case scenario 2, we have a 45-year-old lady with diabetes for 5 years, MAFLD, poor lifestyle, again, more than 10 medications, a lot of self-prescribed medications here. So what are the outcomes of these patients? If you look at the clinical course of patient 1, fairly all her parameters seem to be under control. She's even following up with bone density periodically. And if you look at the clinical course 2, again, we could certainly do a better job with her glycemic control or hypertension. She's already on stage 2 fibrosis in fibroscan, and her cholesterol parameters can be little better. So if you look at the medication adherence, so a lot of times we think if you have more medications on the list, the adherence or the compliance to the prescription is less. There's no doubt about that. That is true. But the studies have also looked into the hyperpolypharmacy, and they have said if the patients are educated about the need for the drugs, why they are taking it, and if the medication reconciliation is done at appropriate levels between different consultants, say you examine what the cardiologist is giving you, or if you're treating the patient for osteoporosis, you educate the importance of calcium, fall precaution, and bisphosphonate therapy. And then, a diabetologist or a physician takes care of the diabetes. If you put together all of these and educate the patient, even if the patient is on more than 10 medications list, the adherence to the drug can be kept at a reasonably good percentage, and that's what the studies have shown. And this is exactly what we see in clinical case summary 1, high adherence to the prescribed medication. In case number 2, there is a poor adherence because a lot of self-taken over-the-counter medication. So what are the effects of polypharmacy? Why are we having this discussion here today? Is one, for the poor compliance of the patient, drug-to-drug interaction. Overall, it has shown to increase the mortality, hypoglycemia risk increases in patients with diabetes, falls and fracture risk increases, and there is also a cognitive decline which has been reported with polypharmacy use. So now coming to the question of whether this is appropriate or this is a cause of concern. So இது வந்து ரெண்டா பிரிக்கலாம். You can call this as either an appropriate polypharmacy or an inappropriate polypharmacy. That's how it has been defined, or that's how the polypharmacy is defined here. So what makes the polypharmacy appropriate? Every medication is a clear indication, like case number 1. Diabetes drugs, the guideline management therapy. Bones, you have the anti-resorptive drugs. The cardiologist prescribed statin, antihypertensive, and the blood thinners. There are no duplication or interaction, so the patient should not be on multiple vitamins or multiple forms of vitamin D and calcium preparation. And you document every time the patient comes, there is an improved outcome. Yes, the bone density is improving. Yes, we see an improvement in the diabetes scores. We see an improvement in the blood pressure. Overall cardiovascular status is stable. So every time you document an improved outcome and you put it in your electronic medical record or your written records, and regular periodic reviews are performed in the medication, then that polypharmacy is called appropriate polypharmacy. And when do you call this an inappropriate polypharmacy? When there is a medication without clear indication. In clinical case number 2, vitamin E is no longer recommended for diabetic patients with MAFLD, right? Some of these medications are self-medications. We don't have, even though curcumin has some data, patients have been self-medicating with a lot of over-the-counter drugs. So if you have a medication that has no clear-cut indications, then that could qualify as a polypharmacy that is inappropriate. Overlapping pharmacological classes of drugs, the common that we see is a common use of both GLP and DPP-4 in the same prescription. So adala small errors. It's like, as I told you before, a proton pump inhibitor with domperidone, which I think in our country flows through the tap water. Everybody is on PPI with domperidone. So putting them on cabergoline or dopamine agonist to sort of regularize the cycle and sort of mitigate the effects. So all these things are, something that we could sort of avoid, and using of necessary supplements which are required for the patients, then we call this as a polypharmacy that are inappropriate. So I will finish off. I know I have 5 more minutes time here. This is the last slide of my presentation, last few slides. What are the 10 practical pearls that we can do in terms of polypharmacy? One, as sir said, review medication. Najamave effectiveness irka? Are we using it? Patient olunga edukrangla? Every time the patient comes, you ask, what has changed between this visit to last visit? Even it could be as simple as thyroxine. They will skip the medication. They won't take it the way it's supposed to be taken, right? So ask them if they are taking to the medications regularly, or if there is a duplication to the med list. It's very important. So that's a very simple question that you can ask the patient, what has changed from the last time that I saw you to this time? Right? And then the patient would say, this happened, I stopped this medication. I've had patients who have stopped steroids without knowing. I recently had a patient who was on Medrol. The rheumatologist changed it to Deflacort, and the patient didn't know both were steroids, and she completely stopped Deflacort for about few weeks and came with adrenal insufficiency. So it's important that we talk to the patient, document and educate them about this. Establish de-describing protocols. If your patient's neuropathy is better, then slowly withdraw the medication. They don't have to be on this combination of pregabalin with so many vitamins put together, right? So I've seen patients who are on pregabalin forever, and we know the side effects of those medications in terms of the cardiovascular risk, etc. So always have an established de-prescribing protocol. தேவையில்லைனா அந்த மெடிசனை கொஞ்சம் கொஞ்சமாக withdraw பண்ணி we need to take it off the medication list. Individualized treatment plan. Promote lifestyle. எங்கெல்லாம் lifestyle முடியுமோ, like for example, even if there is a postprandial blood glucose excursion, see if you can cut down the carbs and add more protein and fiber to the diet, right? So you can promote lifestyle medicine as a very strong prescribing thing. Use shared decision making with your patient, saying that I'm using this drug for this and this, and I would like for you to continue. A lot of times we see people discontinuing statins, which is not something that we want our patients to do. Tell them why this is important, why it is important for them to continue the medications that you actually ask them to continue. Collaborate with the pharmacist. I think this is very important. Namakku time illana, we can ask the pharmacist to review the medication or educate them or do the teaching, or the nurse practitioners to do the teaching. Avoid ineffective combination therapies, as I mentioned to you previously, and prevent prescribing cascades. Don't use another drug which is causing the side effects. Adukku innonu drug use பண்ணாம இருக்கிறது better. Ensure documentation is very good in your EMR or in the records that you have, and optimize early disease management. If we control diabetes early, that's exactly the point. We would prevent a lot of these complications. The drug list can be minimized in the future. So that is the whole point. If you could optimize the early disease management, then the complication or the need for further increasing the therapy or the cost of the therapy or the overall burden to the patients from the pocket again would come down. So the additional recommendations are, you can use stop and start therapy, which is available in the geriatric world, where you have this using of the right medication, using of the medication to stop the medication that you're not requiring. Similar to that is Beer's criteria, where they have the criteria of what drugs can be used, which medication increases the falls and fractures, etc. And pill boxes and apps are there. Appல டிக் போடுற மாதிரிலாம் வந்திருக்கு, where they can use those apps to say if they are taking the medications regularly. And in the future, of course, you can integrate your EMR with AI. You know, AI could sort of identify, oh, in the rendu drug podringa, this drug will interact with this drug. You know, all those things would probably help, you know, to sort of reduce the polypharmacology outcome, and this would strengthen the patient education campaigns as well. So with this, I summarize saying that polypharmacy is not inherently harmful, but inappropriate polypharmacy must be addressed. A judicial prescribing, a regular review of the medication, regular de-prescribing of the medication, shared decision with your patients and the family is the key. So balance always benefits with the risk. With this, I finish, and I thank the organizers for this opportunity again. Thank you. And once again, thank Novo for this opportunity, allowing me to present my slide deck. Thank you.